Welcome back to the deep dive. Today, we're taking a focused look at a really critical topic, leukemia in children. Now, our source material for this deep dive is a bit different. It's a set of highly focused revision notes, specifically designed for medical learners getting ready for exams like the MSRA. Think of them as like a really dense roadmap to understanding this condition.
That's right. And our mission today is to be your guides through that roadmap. We're going to unpack these notes, pull out the really crucial high-yield information, the stuff you absolutely need to know. So whether you're revising, prepping clinically, or maybe you're just really interested in pediatric health, we want to make this complex topic clear and hopefully memorable for you. We're not just looking at what the notes say, but we'll try and dig into why it's important, connect the dots between the different sections, from how it starts to treatment and what the outlook is.
Yeah, the goal is really to take this detailed info and make it digestible, highlighting the key takeaways so you can build a strong understanding fast. Okay, let's dive right in then. Section 1, defining it. According to these notes, what exactly is leukemia in children and how common are we talking?
So, at its heart, it's a cancer of the blood cells.
Yeah.
And the notes make it really clear from the get-go. It is the most common cancer in children. It actually makes up about 30% of all pediatric cancer cases. That's a big slice.
30%? Wow.
Yeah. And interestingly, the notes mention these peak incidence ages pretty early on, around age 3 for boys, age 2 for girls.
Yeah.
So while it can happen anytime, there are definitely these sort of peak periods.
Okay, so it's the most common, peaks early, and the notes break it down into types.
They do. And the percentages here are really high yield, definitely worth remembering. Acute Lymphoblastic leukemia, that's ALL, is way out in front. It accounts for like 78% of cases.
78%.
Yeah, which makes all the single most common cancer overall in kids, as the notes point out. Then you've got acute myeloid leukemia, AML. That's about 15%. And the notes highlight a slightly different pattern for AML. It's most common in infants, so under 1 year old. And then it has pretty consistent rates from age 3 or so onwards.
Oh, interesting difference.
Then there's chronic myeloid leukemia, CML, making up maybe 5%. And the rest are rarer types. The notes specifically say chronic lymphocytic leukemia, CLL, which is common in adults, is exceptionally rare in kids.
Right, so the big picture is childhood leukemia usually means ALL, with AML as the second main player.
Exactly. Getting that landscape right is like step 1.
Okay, so once we know what it is, the notes quickly get into how the etiology and pathophysiology. And what's fascinating is that it's not just one thing. Leukemia stems from these diverse biological processes, but the common thread is abnormalities at the genetic or chromosomal level.
Right, and this is where it gets really interesting, doesn't it? Because understanding the specific genetic glitches helps explain why the types are different and, crucially, how we treat them. The notes link specific genetic issues to types. They do get quite specific, yeah. For T-lineage LNL, which is a subtype, they mention translocations involving the TCR loci. Basically, bits of chromosomes swapping places and messing up the genes that control T-cell development.
Okay.
For the more common B-lineage ALL, the notes talk about mutations in transcription factor genes. These are like the master switches for other genes. So mutations in genes like PAX5, TCF3, EBF1, they disrupt the normal development of B cells.
Like the instruction manual for building the cells gets corrupted early on.
That's a great way to put it. Exactly. Yeah. And for AML, it's a similar idea disruption of other transcription factor genes, like CBF is the example given.
Yeah.
Again, it leads to abnormal gene regulation in the myeloid cell line.
Right.
And CML has that really specific famous one, the BCR-ABL1 fusion gene.
Ah, yes, the Philadelphia chromosome.
Well, the fusion gene product, yeah. It creates this protein, a kinase, that's basically stuck in the on position, driving cell growth constantly. And this is a huge point because, as we'll see later, there are targeted drugs specifically for this BCR-ABL1 protein.
That's a perfect example of how knowing the how directly leads to the what to do about it. So these genetic problems, who's more likely to develop them?
Let's unpack the risk factors mentioned in the notes.
Okay, the notes list quite a few. There are some general patterns, like it being slightly more common in boys and in white children compared to black children. But a really critical category they highlight is the link with specific genetic syndromes. This is definitely a high-yield area to focus on for revision.
Okay, like which syndromes are we talking about?
Down syndrome is a big one. The notes state kids with Downs have a significantly higher risk, somewhere between 10 and 20 times higher, maybe 15 times, depending on which part you read. That's a massive increase.
Wow.
Others mentioned are Fanconi's anemia, ataxia telangiectasia, and Bloom syndrome. Bloom syndrome is described as this rare inherited condition linked with short stature, but also a much higher cancer risk generally, including leukemia.
So if you see a child with one of these conditions presenting with certain symptoms, leukemia jumps up the list of possibilities. Absolutely. It should be high on your differential.
Okay, so underlying genetics are key. What about environmental factors?
The notes cover those too. Significant exposure to ionizing radiation. Think high doses where certain chemicals are listed. A specific example given is maternal abdominal x-rays during pregnancy.
Right.
Also, maternal infections during pregnancy are mentioned as a potential link from some studies, and the infant microbiome is noted as, an area under research.
And what about things like power lines or mobile phone masts? That comes up sometimes.
Yeah, the notes address that directly. Electromagnetic radiation from power lines or masts, and also low-level radiation from the nuclear industry. While they've been suggested as links, the notes are very clear. These are not conclusively proven epidemiologically.
That's an important distinction. So strong links for specific syndromes and high radiation doses, but some other environmental suggestions are still unproven.
Exactly. It's a mix, and the notes help differentiate the established from the speculative. Now, then there are autoimmune conditions like lupus, SLE, or juvenile idiopathic arthritis, and finally, other hematological conditions, problems with the blood or bone marrow itself. That includes things like aplastic anemia, Fanconi's anemia, again, which is both a risk factor and a differential megaloblastic anemia, certain lymphoproliferative disorders, myelodysplasia, myelofibrosis.
That is a long list. It really highlights that symptoms like fatigue, fever, paleness, bone pain, they could point to many different things initially. So how do doctors narrow it down from that wide range? Let's talk investigations.
Right. The notes lay out a clear pathway, and often the first step happens in primary care, like the GP's office.
Okay, what's the absolute crucial first test according to the notes?
It's the full blood count, the FBC, and looking at the blood film under a microscope. A key finding mentioned is often pancytopenia. That's low counts of red cells, white cells, and platelets because the bone marrow is getting crowded out by leukemia cells.
Okay, low counts.
But the real clincher, the thing the notes really flag up, is seeing blast cells on the peripheral blood smear. These are immature white blood cells that shouldn't really be circulating in large numbers.
Blast cells. Got it.
And the notes are emphatic. If you have an abnormal FBC or film, especially with blast cells, plus other suspicious symptoms, that equals an urgent referral to a specialist pediatric oncology center.
Urgent referral.
Okay.
So the FBC and film act as the alarm bell. What happens at the specialist center to confirm the diagnosis?
That's where they nail it down. The gold standard, according to the notes, is a bone marrow aspiration and biopsy.
Right.
This lets them look directly at the cells being made in the bone marrow, see the leukemia cells, and figure out how much infiltration there is.
Okay, definitive diagnosis. What else?
Other key investigations include imaging, like x-rays or scans, to see the extent of disease, although the notes make a good point that leukemia isn't staged like solid tumors. And then, really importantly, immunophenotyping and cytogenetic analysis on the bone marrow sample.
Ah, the fancy tests. Why are they so important?
Because they give crucial information for risk stratification. They look at specific protein markers on the leukemia cells and check for those chromosome abnormalities we talked about earlier. This helps decide if it's standard risk or high-risk leukemia, which, as the notes stress, directly guides how intense the treatment needs to be.
Okay, so it dictates the treatment plan.
Exactly. And a lumbar puncture, a spinal tap, is done if they suspect the leukemia might have spread to the central nervous system, the brain, and spinal cord.
You mentioned leukemia doesn't use classic staging. What factors do the notes say are used for risk stratification, though?
Right. Instead of stage 1, 2, 3, 4, they look at things like the initial white blood cell count, platelet count, the child's age at diagnosis, whether they had a prior blood disorder, how enlarged the liver and spleen are, those specific chromosomal abnormalities found in the cytogenetics, and also evidence of bone damage. The notes mention an older system, the FAB classification for ALL, but say it doesn't correlate as well with prognosis as the modern immunogenetic classifications. For CML, staging is more about disease activity and whether it's progressing towards a more acute phase.
Okay, that makes sense. So diagnosis confirmed, risk level assessed. Now the big one, management. What do the notes say about the treatment plan? It sounds like a really intense process.
It absolutely is. And the notes wisely start with some broader points about support, which are critical. They really emphasize the need for long-term support for the entire family, involving different agencies, primary care. The diagnosis impacts everyone's schooling, siblings, parents' work.
That's such an important point.
Yeah, and they mention open communication among all the healthcare staff is vital. Treatment is mostly in specialist centers, but there's often shared care with local hospitals. Connecting families with other families going through it is also highlighted as beneficial. Oh, and a key practical point. No routine childhood immunizations during treatment and for 6 months after.
Got it. Important practical details. Now, what about the specific medical treatments for the different types?
Okay, for all L, the most common type, the notes describe high-intensity chemotherapy. It's usually given through a central line, like a Hickman line. The exact schedule varies based on the risk group. And the notes specifically mention that adding the drug asparaginase was a major breakthrough that improved survival rates.
Okay. What about transplant?
Allogenic bone marrow transplant using a donor's stem cells is an option, but the note suggests it's generally kept for high-risk cases or if the initial chemo doesn't work well.
Right. And for AML.
Also intensive chemotherapy. The aim is to wipe out the leukemia cells quickly. And because the treatment really knocks down the normal bone marrow function, a lot of supportive care is needed, blood transfusions, antibiotics, etc. The notes point out AML is challenging because it has so many different genetic subtypes. So there's a real need for targeted therapies because just making the standard chemo more intense hasn't led to big gains.
So targeted therapy is especially key for AML. What about CML?
For CML, the notes mention imatinib. That's one of those targeted drugs, an anti-tyrosine kinase inhibitor that specifically targets the BCR-ABL1 protein we talked about. It's been very successful in adults, and it's used or studied in kids too. For a potential long-term cure, myeloablative stem cell transplantation is also mentioned for CML.
So very different approaches depending on the type and the underlying genetics. How do they help the child's own blood system recover from all this chemo?
Good question. The notes mention colony-stimulating factors like GCSF. These are injections given after chemo to kind of kickstart the bone marrow, encouraging it to produce healthy white blood cells faster. This can help reduce the time spent in hospital and lower the risk of serious infections when the immune system is down, like febrile neutropenia. Now, despite how tough the treatment sounds, the prognosis section in these notes is actually quite remarkable.
Yeah. Let's talk about the outlook. How much has it improved?
The progress is incredible. The notes give some stats. 5-year survival for all childhood leukemias combined went from just 33% back in 1971 up to 79% by the year 2000.
It's a huge jump.
Massive. And cure rates went from about 25% to 68% in that same time frame. It really shows the impact of decades of research and better treatments.
That's fantastic news. How does it break down by type? Is all L still better?
Yes, for all L, the outlook is generally excellent now. The notes quote an overall cure rate of around 90%.
90% cure rate for all.
Amazing.
It really is. And outcomes are often even better for kids diagnosed between 1 and 10 years old.
Okay, and AML. AML prognosis has also improved significantly. The notes suggest a 5-year overall survival is now around 70% in high-income countries, with event-free survival around 56%. But there's a caveat. The notes highlight a tougher group within AML, those with unfavorable cytogenetics or who don't respond well initially. For them, sadly, the cure rate is still low, maybe less than 20%, even if they get a transplant.
So AML is still a bigger challenge than IL, particularly for those high-risk subtypes, but overall much better than it used to be.
Definitely. And the notes look forward to anticipating more progress with new therapies targeting those specific molecular faults we discussed. The aim is more personalized therapy, better cure rates, fewer side effects.
Which leads us nicely, or perhaps not so nicely, into complications. This intense treatment doesn't come without risks. What does that list look like in the notes?
It is a significant list, and the notes break it down well into early, during treatment, and late complications.
Yeah, what are the early ones? Things that can happen right at the start.
Early on, big risks include neutropenia, leading to sepsis or coagulation problems, thrombocytopenia, low platelets, causing bleeding, even stroke, electrolyte chaos from tumor lysis syndrome when chemo kills lots of cells quickly, releasing potassium, phosphate, acute airway obstruction if there's a big mass in the chest, Leukostasis, where too many white cells clog blood vessels, risking stroke or lung problems.
Hmm.
And CNS involvement causing seizures. So some really acute, life-threatening possibilities.
Wow, yeah. Very serious risks up front.
Mm.
What about during the main course of treatment?
During treatment, ongoing issues include tumor lysis syndrome again, potential kidney or liver impairment from the drugs, continued immunosuppression and risk of sepsis, blood clots, thromboembolism, and then the more classic chemo side effects, alopecia, hair loss, severe mucositis, really painful mouth and gut sores, hyperemesis, bad nausea and vomiting, and GI erosion or bleeding.
Okay, and then the late complications, the ones that can show up years later.
Yeah, this is a really important area for survivors. The notes list things like growth hormone deficiency leading to short stature, neurological problems like chronic headaches or cognitive difficulties, peripheral neuropathy nerve damage, specifically linked in the notes to the chemo drug vincristine.
Ah, good to note that specific drug link.
Yes. Also, obesity later in life, congestive cardiac failure linked to certain types of chemo like anthracyclines, broader cognitive impairment affecting learning or memory. Infertility is a major concern, psychosocial difficulties, and sadly, an increased risk of developing a second, different cancer later down the line because of the treatment they received.
That list is really sobering. It shows that beating the leukemia is often just the beginning of a longer health journey for survivors.
It absolutely does. It underscores the vital need for long-term follow-up and support for these kids as they grow up. So, reflecting on everything in these notes, the fact that ALL is so common, the specific genetic drivers, the FBC and bone marrow being key for diagnosis, the risk stratification guiding treatment, the intensity but also the success of modern therapy, that huge leap in survival rates, and then that whole list of potential long-term effects.
Yeah, looking back at all of that information, what's the one thing that really stands out to you?
Well, given that incredible progress in survival, which is fantastic, but balanced against that significant list of late complications, it makes you think, doesn't it? The notes seem to point towards this shift. How does the focus in caring for childhood leukemia survivors change over the long term? It's not just about being cured anymore, is it? It's about the quality of that survival. And maybe the provocative thought is, how does that ongoing research into more targeted, personalized therapies fit into this challenge? Can we maintain those high cure rates while dramatically reducing the long-term costs for these children?
That's a really powerful point. Balancing the need for aggressive treatment now with minimizing the lifelong impact later. It highlights the ongoing evolution of care and research in this field. Well, thank you for joining us on this deep dive into childhood leukemia, drawing from these detailed revision notes. We really hope unpacking it this way has been valuable for your learning or revision. If you are preparing for the MSRA or similar exams and you found this focused, high-yield approach helpful, you can find loads more structured revision materials over at PathomSRA.com. And don't forget, there are also extensive free resources available to help you prepare at FreemsMSRA.com. Thanks for listening. Until our next deep dive, keep learning and keep exploring.